Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey. Insights that matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lillie Shockney.
Hi, this is Lillie Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. Today we are joined by oncologist Dr. Nilo Azad, who is an associate professor of oncology and directs the Developmental Therapeutics Clinical Trials Program for the Johns Hopkins Sidney Kimmel Cancer Center. Today, this is going to be a special podcast because we're going to be discussing colon cancer. So welcome, Dr. Azad.
Thank you so much. I really appreciate you having me here today.
According to the American Cancer Society, the death rate, which is the number of deaths per 100,000 people per year from colorectal cancer, has been dropping in both men and women for several decades. Some of the reasons for this: colorectal polyps are now being found more often by screening and removed before they can develop into cancers, or cancers are being found earlier when they are easier to treat. And then the other reason is looking at treatments for colorectal cancer has improved over the last few decades. As a result, there are now more than 1.5 million survivors. I have a cousin who very recently became a survivor, just having finished his treatment. Although the overall death rate has continued to drop, deaths from colorectal cancer among people who are younger than the age of 55 has increased 1% per year from 2008 to 2017, which is certainly worrisome. Why do you think colorectal cancer deaths have increased among this particular younger patient population? And this has recently been brought to the forefront of everyone's attention by the sudden death of Chadwick Boseman. Is he typical of the increase in colon cancer among young adults?
First of all, I'm so glad to hear about your cousin being done with his treatment and hopefully continuing to do well. There are many reasons behind why we are seeing this rise of colorectal cancer in younger people. And the honest answer is that we can't really narrow it down and say that there's just one reason. But when you do what's called birth cohort analysis, when you look at groups of people that were born in certain years, and then how do those people do as they get older, it's very clear if you look over what's happened in the last 30 years that our younger folks are starting to get more and more colorectal cancer. Now, it's important for us to say that that's still rare in that population, right? So if you're in your 30s or you're in your 40s, you have a very low risk of developing colorectal cancer compared to if you're in your 60s or 70s. But when you look at everyone in total, 20 years ago, the average age of developing colon cancer or colorectal cancer was 72. And now that number has come down and is in the mid-60s. And that's because more and more people are getting diagnosed earlier. So you asked, why is that? And where is that happening is another part of that question. And we're seeing this more in the West. If you look at what's happening and you look at the fact that there may be a geographical part of it, then you really start wondering whether there are things that are diet related, for example, that could be meaningful. Of course, exposures. So if people are exposed to certain toxins in one area versus the other. But with colon cancer and rectal cancer, we're not really thinking this as an exposure issue, some kind of chemical or carcinogen exposure. It's more likely that this is something that has to do with diet. Something related to that is how much obesity we're dealing with in the United States and in the West, and how sedentary people are. Those are all things that we actually have scientific correlations for. So if someone has a higher body mass index, if someone is more sedentary, there was a study that showed that if people watch television more than 14 hours a week, that they were at increased risk for developing colorectal cancer. Those are things that we can point to and say broadly, those things are potential causes. But clearly, everyone who watches a lot of television, thank goodness, otherwise my kids would be in big trouble. But anyone who watches a lot of TV or people who have a little added weight, all of those people are not going to develop colon cancer. So it's one potential reason, but it's not the underlying full reason. We're still trying to understand that.
What are some early warning signs and symptoms of colorectal cancer that someone needs to be cognizant of so they are paying attention to their own body?
depending on what part of the colon is affected, has somewhat different symptoms. Your colon starts on the right side of your body, and then it traverses across your body and moves into the left side. And then finally, your rectum. And if you have right-sided colon cancer, those symptoms are a little bit more insidious, a little bit more vague. People can develop weight loss, they can have bloating, they can have just changes in what their stools look like. Meanwhile, on the left side of your colon, you're more likely to present with having rectal bleeding and some discomfort. And so that's why left-sided colon cancers are often diagnosed at an earlier stage, because having blood in your stool is a very apparent symptom, whereas the right-sided symptoms often get masked for a while. In our younger patients, often they get thought of as being something benign. So if somebody is having a little bit more constipation or some bloating, people can associate that with just having irritable bowel disease. People often in their 30s and 40s are under a lot of stress with family responsibilities and work. A lot of that ends up being an issue in terms of delay in diagnosis.
What do you consider to be the theorized causes? So we've talked about what we eat and obesity. Can you also talk about, are there differences among minorities? And are there also differences related to genetic mutations?
Yes, there are some differences. So let's go to the molecular and genetic component first. The vast majority of colorectal cancer happens in people that don't have a genetic predisposition for it. They're not predisposed to it because of their family history, but there is a sizable minority of patients who do have a family history. In fact, it's the biggest and most tight risk factor in terms of correlation to developing colorectal cancer. If someone has a family history of colorectal cancer, if they have a family history of polyps, they're more likely to have polyps. And there are mutational differences in those patients. So the most common familial reason that people develop colorectal cancer is something called Lynch syndrome or hereditary non-polyposis cancers. And that is a mutation in one of 4 genes. And if a person has a mutation in one of those 4 genes, they're at a very high risk of developing colorectal cancer. Those families also have increased risk of other cancers. So for women, they're at increased risk for endometrial and ovarian cancer as well. In fact, the highest risk is for endometrial cancer. And so it's not just a family history of colorectal cancer that matters, but the overall family history of cancer. And then, of course, you tie that to a particular molecular mutation. In terms of racial disparities, colorectal cancer has the same challenges in terms of racial disparities and access to care that unfortunately is such a major part of healthcare in the United States. For many years, people who are African American would present at a later stage of disease, and there was some question about whether potentially the disease was more aggressive as well. Over time, some of that has changed because there's been more focus. So I think there's some part of it that's a great success story, that because there's been more focus on colorectal cancer screening in people that are African American, those numbers have actually improved. And meanwhile, the greatest rise that we're seeing is in white non-Hispanic patients. There are clearly some issues that are involved when it comes to racial disparities in access, but we are starting to see some of that improve.
For obesity, something that I was in a discussion with someone about very recently is that in order to eat a healthy diet rich in fruits and vegetables, which should help in reducing the incidence for colorectal cancer, those foods, unfortunately, are more expensive than a big bag of potato chips.
Yeah.
And so for socioeconomic challenged families, they're migrating, as they naturally would, to getting things that are quick and fast, may not need to be cooked or prepared, that everybody likes, but it's not in their best interest from a dietary perspective. And being able to change that means we need to change how much things cost and how accessible they are, which is quite difficult.
Yes. And so I think that we're getting into a little bit of public policy, but I think it's really important when it comes into the context of healthcare, because these things that happen on Capitol Hill and in state houses are not divorced from the realities of how we can improve people's healthcare. It is true that people who have socioeconomic disadvantages are going to have challenges when it comes to being able to afford some of the foods that would be better for them versus not. But there are ways that that can be improved upon. I mean, there's clearly government programs that can help with that as well. The other piece of this is that we need to make sure that people have that information, because I think that education can often be a big part of making some of these choices as well. And a lot of times our citizens that are socioeconomically disadvantaged don't have the access to the information to know about these decisions. For example, when we talk about modifiable risk factors, there is a wealth of really meaningful data looking at high fructose corn syrup and its association with development of colorectal cancer polyps and potentially even colorectal cancer. And that data is pretty compelling when you look at it. There's data both in the laboratory when we look at animal models of cancer, and then there's observational data when we look at people and the amount of high fructose corn syrup, what the intake is, and then the eventual association with the development of polyps. So it's in people too, not just in animal models. But that requires people both understanding that and really moving into a public policy area where sugar drink makers and high fructose corn syrup has a lot of cachet in the agricultural world. I think that those are difficult. These are difficult issues in terms of making sure that people are informed. And in an environment where we're not sure where people stand or how people agree on regulations, the least that we can do is make sure people are informed, because there may be very valid disagreements on how much these industries should be regulated, but at least everyone should have the information.
My specialty is breast cancer, and we saw initially we were looking at the very wide differences between African American women and Caucasian women, with Caucasian women having a higher survival rate, usually being diagnosed at an earlier stage. But then there was a few years ago, it actually was determined that biologically, when we look at the cancer cells, there is a difference for African American women versus Caucasian women that directly contributes to them having a higher mortality and being diagnosed at a later stage. Is that part of your research that you or your team members are doing, comparing one race or ethnicity to another?
That's not the focus of my research, but it is the focus of other people. And we're actually putting in a large grant into the NCI to look at minority health. And it will be an area that we're very interested in looking at. It has been looked at in colorectal cancer to some extent. I think that the people in breast cancer, the researchers in breast cancer and prostate cancer have really led the way in doing some of these analyses. And so colorectal cancer does have some data. And I don't think that we're seeing the same really strong association between biology differences. I still think there's a lot of room to look. And the other thing is it's not a monolith either. So there isn't just all people that are white and all people that are non-white, all Hispanic or all Black. There's subsets even within those groups. And so being able to try to parse out some of that, which now we can do with some of our more advanced molecular technologies, will allow us to be more sophisticated in how we look at things and even how we look at racial groups, because racial groups are also different, even when we try to label them with one broad title.
So let's talk a little bit more about some of the modifiable risk factors. So we know healthy diet, rich in fruits and vegetables, certainly would help. Can you name a couple other factors that an individual would have control over that would help them not end up being diagnosed?
I'm going to divide this into two categories. One category is day-to-day modifiable risk factors. People shouldn't smoke. People should minimize how much red meat and processed meats that they are taking in. That is something that correlates with colorectal cancer. People should eat high fiber diets. That's a minor risk factor or modifiable factor, but is something there as well. People should not be sedentary, so people should be active, and that will help with health in many different cancers as well as cardiovascular health. And then, of course, there's the obesity component that we discussed as well. So those are all things that are under our day-to-day control to work on. But the biggest modifiable risk factor is screening. It's not day-to-day, but it is year-to-year that people should get their screening. For Chadwick Boseman, he was too young, even with any screening guidelines that we would have given. He was diagnosed in his late 30s. But that is less common. The majority of people, even with young onset colorectal cancer, are diagnosed in their 40s. The American Cancer Society has moved up their screening to to 45 for normal risk people. This is meaningful for people with late onset colorectal cancer too, that if you get your screening, it is a very preventable cancer. It has a very known progression from normal colon to becoming a polyp to becoming a cancer. And so if you catch people before they have colon cancer, when they just have a polyp, you can get rid of that future cancer. That's the biggest one that I would push.
Yeah, true prevention at its best. Absolutely. If a patient has had a polyp removed last week and they say, I really do want to reduce my risk, I wonder if it's too late for me to be able to truly reduce my risk. Would they benefit as well by starting a healthy diet and exercising, etc., today, at which point in time we know that they are polyp-free, versus do we need to start them as a child or teenager with a healthy diet and exercise and such? I look at kids today and they're sitting in front of a computer or a hand thing, and during COVID, they're sitting in front of a computer for school even, right? So They're not up and about. They may not even be able to go outside and play for that matter. And so I wonder, is it ever too late to begin doing these modifiable factors?
No, it's not, because colon cancer and rectal cancer risk doesn't end at any particular age. If you are someone who is 35, 45, 55, or 65, you can still develop colorectal cancer when you're 75. And so you can start a healthier lifestyle. And the beauty of the human body is that things that are healthy for one organ or for one kind of cancer actually are healthy for almost everything else. And so it allows us to really focus on general health. We're doing it not just to modify our colorectal cancer risk, but it's going to help our risk factors for any number of cancers as well as cardiovascular issues as well. And if you put all that together, that's the top many leading killers. So you get to leverage that by using it against everything that comes for us as we get older.
You had mentioned about the screening recommendations with the American Cancer Society going from age 50 to now age 45. Can you talk a little bit about if you do have a first-degree relative or several first-degree relatives, so that you have a higher risk because of that family history, would that age of 45 change for someone who does have a family history?
Yes. The recommendations for screening for someone who has a first-degree relative with colorectal cancer is to start screening 10 years younger than whoever the youngest person was. So if you have a family member that's in their early 40s who developed colorectal cancer, first-degree family member, you need to start your screening in your early 30s. So that 45 number is for normal risk individuals. You're not a normal risk individual if you have a first-degree family member who has colorectal cancer.
What are the surgical treatment options available now for colorectal cancer?
There's been a lot of great developments and more advanced surgical techniques to be able to treat colorectal cancer. There's laparoscopic removal of colorectal cancers, robotic surgeries. We have surgical techniques where we can even operate on people who have metastatic colorectal cancer, stage 4 disease, with curative intent. So being able to cure a sizable segment of patients, even with metastatic disease if it's limited. And that includes surgery on liver metastasis. So if the cancer is spread to the liver, to the lungs, and even to the abdominal cavity. So, that's a big area. My interest is very focused on metastatic colorectal cancer. And of course, this kind of a podcast, we hope helps people never have to get to that point. But even in that setting, I think that there's a lot of really interesting surgical techniques that have come up. Meanwhile, for more early disease, as well as for polyps, there are some more advanced colorectal techniques where people can have pretty minimally invasive surgeries to be able to rid themselves of these polyps.
I'd like to learn a little bit more from you about the exciting research that you are working on, because you've got quite a few things going on, and I think that our listeners would be very interested in that.
In the last 20 years, we have gained so much knowledge about the underlying biology of colorectal cancer. So we've gone from not knowing very much about this cancer except for what we could see under a microscope to now being able to really understand what the abnormalities are in the DNA of a given cancer, what the abnormalities are in the proteins that are in that cancer, and how can we target that cancer in different ways now that we understand it better. As we've understood that better, what we've done as a community, as a colorectal cancer community, is to be able to identify certain molecular changes or abnormalities in the colon cancers and pick drugs that would hit those. And so those have resulted in some really effective treatments. And also kind of understand, how does the colon cancer interact with the rest of the body and with the immune system? And that's been a big question because immunotherapy, the use of the immune system, activating the immune system against cancer, has been very effective in a lot of tumor types. But in 95% of advanced colon cancer, immunotherapy has been non-effective. So there's a small segment of patients, the Lynch syndrome patients that we mentioned, that have a beautiful response to immune therapy. And then it turns out that some people who don't even have Lynch syndrome, their tumors still have a problem with one of those same 4 genes or proteins. And so they also are very sensitive to immunotherapy. But 95% of people that isn't true for. So some of my work is really focusing on, what can we do to reverse that? Are there ways that we can use drugs that are non-immunotherapy drugs, but that might be able to actually help activate the immune system? So combining different classes of drugs together. I've become more recently involved with one of my other colleagues here who has a lab really focused on cancer vaccines. And so her work, Dr. Nilo Azad, she's been working with Dr. Elizabeth Jaffe, who has worked predominantly in pancreatic cancer, but now working also in colon cancer, really focusing on how can we use some of these more advanced, interesting, sophisticated vaccines now than what we used to have. But what can we do to add to that to try to treat colon cancer patients? And we're doing that not only in the advanced setting, so in the metastatic setting, but also, can we keep this cancer from coming back? So even if you get rid of the cancer and you finish your adjuvant chemotherapy, you still have some risk for the cancer coming back. Can we lower that with a vaccination strategy? That's another area of work that I think is very exciting.
That is exciting, absolutely. Looking at the challenges of getting people to come in and get a colonoscopy. And they'll say, I don't have time. I don't want to take off from work. I can't tolerate the bowel prep. I don't know who's looking at my hiney while I'm sleeping. All of these things that worry people. Do you have any advice as to how to inspire folks to do the right thing for themselves?
I find that the most effective way to do things that are maybe not palatable or feel like that you don't have time for them is to think about the impact it would have on your family members if you didn't do this, and what you would tell your mom or your dad. A week ago, I gave an interview talking about the symptoms of colorectal cancer and how so many young people that have these symptoms are so busy with their life that they don't have time to deal with those symptoms, and they assume, which for most people is true, that this is not cancer. I said, I think the metric should be, if my 70-year-old mom, who I love so much, had these same symptoms, would I tell her, don't worry about it? The more we understand that our connection to other people in our lives and how important it is for us to stay healthy for those people, that can sometimes get us over the hump. And that's how I try to talk to the family members of my patients who I'm advising to go in and get scoped, and they may not be as interested.
Dollar Tree has photo magnets for 4x6 and 5x7 pictures that you can stick on your refrigerator. And prior to COVID, when I was last in there 7 months ago, I was stood there and I was looking at the over 2 in a pack, so 2 for $1. And I thought, it would be clever for screenings, particularly colorectal screenings, if we took those magnets and we added at the bottom, this is why I got screened. So we aren't violating in saying what they got screened for. It could be a mammogram, could be a colonoscopy, could be a skin check for melanoma or whatever. But I do find that we can usually inspire someone if they have a little bit of guilt in saying, who's going to take care of your family when you're not here?
Yeah.
Because you may be traveling down the path that you're not going to be here.
Yeah.
So I just read an interesting article about Black individuals being underrepresented in clinical trials. And I'd like to know, what is Hopkins doing regarding that particular patient population as it relates to innovative studies?
We have, I think, really focused on this issue in our community very heavily over the last many years. Hopkins has had a charged relationship with its community over the last few decades. And I think that there is a real thirst in the leadership here to change that feeling and to develop a very trusting relationship with our community. And our catchment area, which includes Baltimore, has a very strong representation of the Black community. And we want those patients to feel comfortable and safe coming and being in clinical trials here at Hopkins. There is a lot of community outreach that is going on. There's dedicated community outreach to tell people about the kinds of studies that we have. We have both faculty and staff that are focused on that effort. We have people that are focused on trying to make it easier. So helping with transportation, helping with some of the costs that come, and really targeting that specifically for our Black community to make sure that we really reach out. Again, I come back to the piece of education, and I think that the more that we can talk to our patients about clinical trials when we are interacting with them and really destigmatize them a little bit, because I think that there are just communities where clinical trials are more stigmatized. And we have to be honest that there's some communities where Hopkins is stigmatized. And so we have to kind of focus and be realistic about both of those things. But I think with the drive that there is and the real commitment to it, I'm hoping that what we're seeing, which is increasing numbers of having minority enrollment in trials, that is going to continue, because we still have lots of room to improve.
I think that one of the things that can happen with clinical trials, patients may need to be coming in for additional appointments associated with the study. And I don't think it's realistic or even appropriate to expect a patient to take off extra days from work in order to participate in a trial. So like if they need a blood test done, I'd rather that happen at 6 p.m.
Right.
Or 7 a.m. rather than at 1 o'clock in the afternoon, when the only way they could do it is to sign out from work and probably not even be able to sign back in. I wanted to share with you 3 slogans that I created more than 2 decades ago regarding colorectal cancer screening that I actually sent to the American Cancer Society. I wanted to see them as billboards, and they wrote me back saying I was a little edgy. And I thought, now you just gave me a national award, now you're telling me I'm edgy. But anyway, here were the slogans that I gave them. Invest in your bottom line, get a colonoscopy.
I like it.
Just don't sit on it, get it checked. And I think it probably was this third one that tipped their scales. Let me give you the straight poop about colorectal cancer.
And now there's poop emojis all over the place. These are T-shirt slogans. They're that good.
See, I was just in the wrong decade, I suppose. Before we close, I also wanted to ask you about what my mom, who's 92, calls the poop test in a box. And what would be the criteria for using Cologuard? And certainly our listeners have seen lots of commercials, I'm sure, on television about it. How accurate is it? And if you fail the poop test, as my mother said, and she did, then a colonoscopy is usually the next step.
Cologuard and other stool-based testing, so they test for a couple of things. They test for blood in the stool, and they test for abnormalities in DNA that suggest that the tumor is shedding and that they're able to capture it. They are quite sensitive and pretty specific in terms of their ability to help screen. And they are better than not doing the tests, but they're not as good as the gold standard, which is a colonoscopy. The gold standard is the gold standard because it not only diagnoses it, you get tissue, but you actually get to take the thing out in terms of polyps. And so Cologuard is, I think, a very great tool that we have, and it is better than nothing. It's much, much better than nothing, but it is still not the gold standard. The other area that we should talk about is liquid biopsies of blood. And so that technology is very exciting. It's not ready for prime time yet, but it is continuing to improve. The idea that we might be able to do a blood draw and capture microscopic pieces of tumor DNA, and hopefully, if we were lucky, polyp DNA, so that we'd be able to diagnose cancer, would be amazing and is a really meaningful step forward in screening. Some of the issues with diagnosing precancerous lesions, though, is that they don't have the same blood supply, so they're less likely to secrete little pieces, which is why the colon tests getting better might also be useful.
Got it. So what gives you optimism each day?
My patients give me optimism each day. I see an extraordinary amount of strength and hope in my patients of all stages. And so I think that I am very lucky that I get to do what I do. We are at a time in science and in taking care of cancer patients when we're finally going to be able to put all of this information that we are learning about how cancer really functions and use that to diagnose it early and to treat it. And now our biggest challenge is trying to figure out how to sort all that data, because for many generations, we just didn't even know or understand. And now we have so much that we have to analyze. The next 20 or 30 years are going to be a sea change in our ability to diagnose this entity earlier, and I think potentially to even eradicate many cancers. So I'm very excited about the next generation.
That's wonderful. Thank you. Thank you so much for joining us today. I know that our listening audience has learned a great deal, and I suspect that if she or perhaps her spouse or partner or other family member has not been following the criteria for getting a colonoscopy, I bet you've inspired some folks to make a phone call and sign up and make that happen.
I sure hope so. Thank you so much for having me.
Thank you.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, and your host, Lillie Shockney, with a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Women's Journey is grateful for the unrestricted educational grants from HRH Foundation and Keswick Wise and Wellness Center that support our podcast series, Insights That Matter. For more information about A Women's Journey, visit our website, hopkinsmedicine.org/A Woman's Journey. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/A Woman's Journey. Until next time, stay well.